Medurstand-Understanding Medicine.
Professor Azizur Rahman, and we are continuing our discussion on various ECG abnormalities, and we are getting actually close to the end of the course. You can see how many topics we have already covered, and today we're going to take this one, electrolyte abnormalities. Before I go into the details of ECG changes and various electrolyte abnormalities, I must say one thing, that you can easily miss these abnormalities if you are not actually anticipating them. So you need to know the clinical settings. And I must admit that it is easy to miss these findings unless you were already anticipating or expecting, right? So if you have a proper clinical setup, then ECG may show classical changes, and they are very fast, and the moment you do an ECG, you have the report with you and you can suspect some electrolyte abnormality. But the gold standard of these electrolyte abnormalities remains actual electrolyte testing. Okay, so with that disclaimer, I'm going to show you, of course it is very useful. Sometimes we make a diagnosis from the ECG. The ECG may be the starting point. You just happen to see the ECG and that shows the abnormality, and when we investigate that patient, then we find the underlying disease. But other times we already know the underlying disease, but we just are following certain electrolyte abnormalities. Now, of course, there are numerous electrolyte abnormalities, but we will be covering only 4 of them. Hyperkalemia, hypokalemia, hypercalcaemia, and hypocalcaemia. And they all have different case scenarios with different clinical settings. So for hyperkalemia, the commonest setting is renal failure, acute or chronic. Of course, there are many others. I will not go into the detail because our discussion is focused on ECG. Now let's see this ECG. Let's examine it. You know, when we see the rhythm, we examine this limb-lead 2, which is a continuous recording, and otherwise we see lead 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. And then the rhythm step, you can see these are P waves, or these are the QRS complexes. Actually, if you see, this would look like P mitral. This one looks like P mitral, but it is actually a QRS complex. How do I know this is QRS complex? Because this corresponds with this one, this QRS complex. This is of course QRS complex. So a simultaneous beat coming in this one is QRS complex, and this is T wave. Okay, and P wave is not visible in this. So let me point out the abnormalities. I'm sure you have figured out some of them, but let me point out some of them and then we discuss them one by one. The very, very obvious tall and narrow based T waves, and they are present almost everywhere. Of course, any wave will be more prominent in precordial leads because generally speaking, precordial leads, they show bigger diffraction, and precordial leads record ECG changes from very close distance. So you see, this is prominent T wave, prominent T wave, prominent, prominent, prominent. All precordial leads, they record a very, very prominent tall T wave with the narrow base. So that is the observation number 1. Most physicians, they will actually make a final diagnosis or at least suspect the diagnosis just from this observation. But please note down, it is possible to have tall and narrow T wave without any underlying heart disease. Or sometimes these may be temporary change in a specific distribution, anteroseptal or anterolateral, may be a very early manifestation of acute myocardial infarction. But when we have these changes, which are present in almost all precaudal leads and they stay for some time, that means they suggest some electrolyte abnormality. Then we have broad QRS complexes. You see, this QRS complex is definitely broader than normal. It may not be as broad as we expect in bundle branch block. It may not be as broad as we expect in ventricular tachycardia, but it is definitely broader than normal. Okay, so in fact, the requirement, the criteria is if you have QRS complexes which are broad, but they do not follow a specific pattern of right or left bundle branch block, then they might be counted as a feature of hyperkalemia. Then you see there is no P wave. Now this is, you can see in this lead, no P wave. This is the QRS complex. Before that, no P wave, no P wave. And here you don't see any P wave. P wave was expected after this T wave, and before this QRS complex there is no T wave. There is no P wave, sorry. So we don't see any P wave at all. This is because P wave is actually laterally stretched. P wave is normally a small wave. When it is laterally stretched, it becomes almost flat. So you don't see. In this case, actually, there is atrial depolarization, but it doesn't show on the ECG. And this is sometimes called sino-ventricular rhythm. Rhythm is sinus, but you don't see atrial depolarization. It is as if the current goes direct from the SNO to the ventricles. So this is a case of hyperkalaemia. I think this ECG in itself is fairly diagnostic. Anybody who has experience would not miss this abnormality. All classical features, but it should be particularly easy if you already are dealing with somebody who is likely to have hyperkalemia like renal failure or many other conditions. I'm not going to go into the details. So this is the listed criteria: global, tall and narrow base T waves. Global mean present in all or maximum number of leads, not restricted to one group of leads. Flattening of P wave, so much so that the P wave is not visible. This is sino-ventricular rhythm. And then broadening of QRS complexes, not to the extent of bundle branch block and not the extent of ventricular tachycardia, and sometimes sine wave pattern. Sine wave pattern means that it becomes like up and down, up and down, up and down, like patient goes into ventricular fibrillation. Now, not only it is possible to make a diagnosis of hyperkalemia, you can actually estimate, and there are various charts available, and if your potassium is 5.5 or less, you have normal potassium, but from 5.5 to like 6.5 or 7, you have these prominent T waves, and then flattening of P wave, and then broadening of QRS complex. As your potassium level rises, then you have more and more changes, and finally, if potassium is 8.5 or above, which is actually very, very dangerous, then you may have sine wave pattern. Sine wave pattern may lead to death because it is practically ventricular fibrillation and patient may not have any circulation. So of course, we would like to take some action before this. Of course, clinical treatment of hyperkalemia is not in the scope of this lecture, but of course you know that we would like to give calcium and there are other measures to control potassium. Calcium is a physiological antagonist of potassium. So if we give calcium intravenously, these changes will immediately reverse. Although serum potassium will remain high, because calcium does not lower serum potassium, it just blocks its bad effects. So immediately you can give calcium, and if you repeat the ECG, you will be pleasantly surprised that ECG is normal. But then you have to do something more permanent about potassium. And this concept is also important, that the changes of ECG changes of hyperkalemia and hypocalcaemia are similar. Okay, so when I show the changes of ECG of hypocalcaemia, you will appreciate this point again. So this is hyperkalemia. Next, now let's see one or two more ECG with hyperkalemia. Again, I think same, very prominent, tall, narrow base T wave present everywhere, and you don't see any P wave. This is a very flat TP interval. I think P wave should have been seen here if it was there. There isn't any P wave. So this is another case of hyperkalemia. Now this is little tricky ECG. I think you have features of hyperkalemia. You have tall T waves, narrow based, but the QRS complex is fairly broad. And I'm not sure if there is underlying left bundle branch block on this ECG. But I had an access to the ECG which was done after calcium infusion, and the ECG changes, these broadening of QRS complex disappear. So although you could suspect left bundle branch block in addition to hyperkalemia, but if the changes disappear after correction of potassium or after administering calcium and the changes disappear, then you could say that these changes are actually due to hyperkalemia itself, not due to any underlying bundle branch block. Similarly, this one is actually even more obvious. This is left bundle branch block pattern and this is left bundle branch block pattern, but this patient also has this prominent T waves, widening of the QRS complex, slightly flattened P wave. So this may also be a case of hyperkalemia. Ultimate, you may suspect, but ultimate evidence of hyper or hypokalemia should be in the form of electrolyte testing. So we have covered hyperkalemia, and I think now you can guess what should be in the logical sequence. Now let's examine this ECG. You have ST depression. This is the isoelectric line. This is the PR interval. If you draw a line here, it should be isoelectric, and you can see that the ST is depressed. So one significant finding in this ECG is ST depression. And this is also widespread. You have ST depression here, here, and even in limb lead. So you have ST depression everywhere. Plus, there are some wide and stunted T wave. You imagine just the opposite of tall and narrow. These are wide. Imagine if you remember those T wave, this T wave is very broad and it is stunted. So broad and stunted T waves. So this is the observation. There is ST depression and there is wide and stunted T waves. And if you magnify it, and you will see these waves, after T wave there is an additional wave, and this wave after the T wave, before the next P wave, there is additional wave, and this is U wave. U wave may be present in normal individuals also sometime, but presence of U wave in proper setting should raise the possibility of hypokalemia. So this is hypocalcaemia, all right? And there are certain clinical situations where you would suspect hypokalemia. Somebody with severe dehydration, fluid loss, diarrhea, fluid loss, I think there you should suspect hypokalemia, and in that setting, the ECG may provide quick diagnosis of hypokalemia, and you can start the treatment, but I always say that hyper or hypokalemia should always be confirmed on blood test. These days we have fast machine. Electrolyte test may be available in maybe 30 minutes. So what are the criteria for hypokalemia? T are stunted, T waves are stunted and wide everywhere. ST may be depressed everywhere. Wide P waves and PR intervals and presence of U waves. So these changes, if present, suggest the possibility of hypokalemia. This is another hypokalemia. You can see the same. There is ST depression, broad, short, broad stunted T waves, and these I think very typical of hypokalemia. Now there is another condition. What do you see here? I would like to draw your attention. This is the rhythm strip. First of all, let's see the QRS duration. The QRS duration is broader than normal, right? And then same should also, the same rectangle should also demonstrate to you that QT interval is also short. From Q wave till the end of T wave, the QT interval is also short. Plus there is an additional wave here. There is a like delta wave, but this is on the down slope of the QRS complex. This is called Osborn waves. So these three abnormalities, broadening of QRS complex, shortening of QT interval, and presence of Osborn waves, suggest the possibility of hypercalcemia. Hypercalcemia, okay? So, of course, I think a very expert can pick up hypercalcemia on ECG, but most people would be able to pick this abnormality only when they were already suspecting hypercalcemia on the basis of clinical scenario. There are various conditions where you could have hypercalcemia. So if you have that condition and you have this ECG would be interpreted as consistent with hypercalcemia, and once you treat hypercalcemia, these changes are likely to go away. Okay, so electrolyte abnormalities are only temporary. Only when that electrolyte abnormality is there, you see the changes. But once that electrolyte abnormality has been treated, then the ECG is reverted to baseline normal. And baseline normal could have some problem like bundle branch block. That will be still there, but the electrolyte abnormalities will disappear. So these are the criteria: short QR interval, short QT, and I've shown you starting from the QRS complex, this and end of the T wave, and it's very short. You can just see the visibly. I think it is short. Wide QRS complexes, you can see they're wide, but not as broad as you see in bundle branch blocks and ventricular tachycardia. And the Osborn, the characteristic Osborn wave. This Osborn wave is not seen in everybody, but if present, especially in addition to short QT and wide QRS, this should raise a possibility of hypercalcemia. It would require the laboratory test, but you can suspect hypercalcemia on ECG. Now we are getting to the end of this, and this is what do you see here? What is your observation? T wave is tall, like you had in hyperkalemia. We have already covered that possibility. Now there is some other electrolyte abnormality. I told you there is something which shows changes just like hyperkalemia, but it is another electrolyte abnormality, calcium, hypocalcaemia. Since calcium and potassium are physiological antagonists, hypocalcaemia would show similar changes, similar ECG changes, not exactly all of them, but some of the changes are just those which we see in hyperkalemia. So this is the tall waves, tall T waves. You can see tall T waves in all leads, even in limb leads. You see these T waves are very prominent. So tall T waves are seen. Then we have QT interval, which looks longer. Before we say for sure that this is long, we would need to calculate QTC, which is corrected QT for heart rate. Now let's magnify this part a bit and see more closely. See, I just measured from the beginning of the QRS complex and end of T wave. This is 0.56, which is longer than normal. Normal is 0.40, 0.405 max. So QT is prolonged. But before we say it is prolonged, we need to correct it for heart rate. But if the heart rate is normal, in this case, heart rate is 75 beats per minute. If heart rate is normal, then observed QT will be the same as QTC. So QTC is also 0.56. That means that condition is fulfilled. This patient had prominent T wave, prolonged QT interval, QTC, and I think the diagnosis of hypocalcaemia should be very, very confident. So these are the criteria: tall R waves and prolonged QTC. You can confuse hypocalcaemia with hyperkalaemia, but changes other than T wave should help. For example, this QTC is actually narrow, is short in hyperkalaemia, it is prolonged in hypocalcaemia. So there may be a situation where there is mixed electrolyte abnormality, like somebody with renal failure on dialysis. There may be mixed abnormality both related to calcium as well as potassium. Only very expert would be able to figure out. Most people will not be able to exactly pinpoint the ECG, would not be able to interpret the ECG in that setting. So that is why I always say the ultimate test for electrolyte abnormalities is blood test, actual electrolyte measurement. But ECG provides a very, very fast and reasonably accurate first indication of electrolyte abnormality, and you may be able to save time, because these abnormalities, particularly hyperkalaemia, may be very serious and can kill in minutes. So I think that gives you an opportunity to save these patients. I would suppose there's a patient of hyperkalaemia, I would, on the basis of ECG, make a diagnosis, start treating, and then immediately send the blood also for testing. Calcium is lifesaver in hyperkalaemia unless it is caused by or it is associated with digitalis toxicity. With that, I'd like to conclude. I hope this video was also useful. And I told you in the beginning that I will not be able to cover all possible electrolyte abnormalities like hypo, hypermagnesemia, and other things. But this was, I think, the common condition which I have covered. Professor Azizur Rahman from Medurstand. I hope you like my videos, and I really look forward to see you in my next one also. And next one is also going to be on some ECG abnormality. Thank you very much.